Welcome to This Explainer. Today, we're unpacking exactly how enlarged tonsils physically block a child's breathing and the absolute domino effect this has on their sleep and behavior. It's a fascinating look at how a seemingly simple structural issue at the back of the throat can just entirely disrupt a child's quality of life. Here's our agenda for today. We're looking at the hidden breathing blockage, the sleep apnea effect, infections versus strep throat, the 7-5-3 surgery rule, and finally, surgery risks and recovery. Let's get right into it. Section 1. The hidden breathing blockage. The mechanics of obstructive sleep apnea. So, is your child snoring just a harmless noise, or is it a sign of a structural blockage? If a child snores loudly or has daytime behavior that looks exactly like ADHD, you might be surprised to learn that the root cause could literally be sitting right at the back of their throat. It's an entirely physical problem. The prime suspect here is hypertrophy. Basically, this just means the enlargement of the palatine tonsils and the pharyngeal tonsils, which we usually just call adenoids. A child's upper airway is already pretty small to begin with, so when this tissue swells up, it severely restricts airflow. In fact, it's the leading cause of obstructive sleep apnea in kids aged 2 to 8. To really picture this physical blockage, the Children's Hospital of Philadelphia describes it as breathing through a small, flimsy straw. Imagine trying to pull a deep breath through a paper straw that just keeps collapsing in on itself. That is exactly what happens when a child's natural muscle tone drops during sleep. The enlarged tissue just caves inward and completely blocks the breath. Let's break down the exact sequence of this mechanical failure. Step 1. The child falls asleep and their muscle tone naturally decreases. Step 2. Because everything relaxes, those enlarged tonsils and adenoids collapse inward, entirely sealing off the airway. And then step 3, this is where the real disruption happens. Because breathing stops, the brain kind of panics and triggers a brief arousal mechanism. Basically, the brain wakes the child up for just a few seconds, often without them even opening their eyes, just to restore muscle tone and rip that airway open to get some oxygen. And this exhausting loop, it can happen over and over and over again all night long. Section 2, the sleep apnea effect, nighttime struggles, and daytime consequences. Look at the stark contrast here between night and day. At night, it's highly physical. Because of that structural blockage we just talked about, you'll see loud snoring 3 or more nights a week, gasping, unusual sleeping positions, just trying to find an open airway, and even bedwetting. But during the day, all that fragmented sleep from those constant micro-awakenings turns into chronic fatigue, morning headaches, and serious irritability. The sleep deprivation causes cognitive and behavioral issues that mimic ADHD so closely that experts say simply removing the tonsils can often completely resolve those behavioral problems. It's wild. Moving to Section 3, infections versus strep throat, distinguishing viral from bacterial. Now, aside from sleep blockages, the other major issue here is recurrent throat infections. When a kid gets a sore throat, it's super easy to assume the worst, right? But as you can see, a massive 70% of pediatric tonsillitis cases are actually just viral, caused by the common cold or the flu. Only about 30% are bacterial infections, usually group A streptococcus. And it is absolutely crucial for clinicians to tell these two apart because the treatment paths are totally different. Viral tonsillitis, that just needs supportive care, rest, hydration, saltwater gargles, and maybe some over-the-counter pain relief. It clears up in about a week, and antibiotics absolutely do not work against it. But bacterial strep throat, that brings a higher fever, those nasty white pus streaks, and swollen tender lymph nodes. It strictly requires a 10-day course of antibiotics to knock out the bacteria and prevent some really severe, though rare, systemic complications, like rheumatic fever and kidney inflammation. Section 4, the 7-5-3 surgery rule, the Paradise criteria for tonsillectomy. Okay, so with both the airway blockages and recurrent infections in mind, when is surgery actually the answer? Well, a tonsillectomy is common, but it's still a major surgery, so doctors globally rely on the Paradise criteria. These are strict clinical guidelines designed to objectively figure out if a child truly needs surgery, helping to avoid completely unnecessary operations. The big takeaway here is the 7-5-3 rule. Surgery for recurrent infections is only on the table if a child hits specific thresholds. We're talking at least 7 documented episodes in just the preceding 1 year, or 5 episodes per year for the last 2 consecutive years, or 3 episodes per year for the last 3 consecutive years. It is a very strict, high bar to clear. And what's fascinating is that these criteria don't just take a parent's word for it. Every single episode has to be officially documented by a clinician. Plus, it has to include a sore throat along with at least one major clinical sign, like a fever over 101 degrees Fahrenheit, tender lymph nodes over 2 centimeters, visible pus on the tonsils, or a positive strep test. It's designed so only the most severely affected kids go under the knife. Now, when surgery is approved, patient safety is the #1 priority, and clinicians look for specific red flags. For example, a sleep study, or polysomnography, is strongly recommended before surgery for kids with Down syndrome, craniofacial anomalies, or sickle cell disease. Also, very young children under the age of 3 face higher respiratory risks, so they require specialized overnight monitoring in the hospital. Finally, Section 5, Surgery Risks and Recovery. Navigating the post-operative period. So the main major complication clinicians are watching out for is post-operative hemorrhage, or bleeding, but thankfully this only happens in about 2 to 3% of pediatric cases. Pain management after surgery is incredibly important, mostly so the child actually keeps drinking fluids. But pay close attention to this warning. Codeine is strictly contraindicated for children. There's no gray area here. Some kids have an unpredictable, rapid metabolism that converts codeine way too fast, which can lead to severe, life-threatening respiratory depression. It is literally off the table. Instead of codeine, doctors prioritize a multimodal, non-opioid approach to manage pain. They also usually give a single dose of corticosteroids right during the surgery. This is a real game changer because it dramatically cuts down on postoperative nausea and helps quickly shrink the throat swelling so the kid can actually breathe and swallow much easier. The whole recovery journey takes about 2 weeks. For the first 14 days, constant hydration is absolutely critical for healing. We're talking lots of fluids and soft, cool foods like applesauce. Between days 5 and 10, parents need to be on the lookout for that secondary bleeding we mentioned, which happens as the surgical scabs start to naturally slough off. Once you hit day 10 and beyond, it's generally safe to ease up on the rest, get back to more strenuous activities, and finally head back to school. So this brings us to a final thought for you to take away from this explainer. After seeing exactly how enlarged tonsils mechanically block a child's breathing, acting like a collapsed straw that shatters their sleep night after night, we kind of have to look at their daytime behavior in a whole new light. If a child is constantly exhausted or acting out, could those behavioral issues actually just be a physical cry for a good, uninterrupted night's sleep? It's pretty empowering to realize that what seems like a really complex behavioral problem might just have a very straightforward, treatable structural fix.